get started. The principle of the topic of tonight's stud is the principles in the management of non-unions, and there's a few learning objectives that I want to get across this evening. So I want to start with a clinical case. I don't want anyone to answer. I just want you to look at this X-ray and just decide for yourself. So this is the post-op X-rays of a patient that ended up being mine later down the line, so you can guess what happened eventually. This is a 43-year-old motorcyclist. She had a previous BKA, so the amputation was not from this accident. She was in a motorbike accident riding a Harley Davidson with a prosthesis, and she sustained a segmental femur fracture that was treated with a retrograde intramedullary nail like this. And there's a series of X-rays. So before I move to the X-rays, maybe just look at this and see if you can predict any problems. Maybe I can ask anyone to volunteer to say if they can predict any problems with this fracture fixation for this fracture configuration. Any volunteers?
I'm Maritz. It's Pieter.
Pieter, ja, wat dink jy?
I think it's not stable enough. If you look at the just looking at the AP, there's only 2 screws in the box, and with the fracture going quite low, just up to the superior polar and patella on the lateral there, but also on the very right side, that interlocking screw there is sitting in a fracture site as well, and it's not and it's shortened there as well, so there's not enough stability there for it to actually allow it to heal.
Okay, good. So you predict problems basically.
Yeah.
Yeah, so I think I agree. If you just look at the distal fixation with the same nail, you could choose locking screws in planes that are more different. So basically, this is quite a distal metaphyseal fracture with the distal fracture, and there's 2 screws in the same plane. And you could have made it more stable by either adding a 3rd screw or at least selected 2 of the screws that are in different planes. And then even more worrying proximally is that you've basically just bypassed the fracture, not a good reduction, and just 1 locking screw there that is not bicortical. Okay, so I'm going to fast forward 7 months. Unsurprisingly, the fracture is not united at 7 months. Now, I'm just going to show you what was done at 7 months, and then I want you to just think for yourself whether you think that would work. So this is what was done. This is the post-op X-ray. Without commenting on whether you think it will work or not, Pieter, do you notice a difference there? What do you notice what was done?
They just took out the 2 most distal screws.
Okay, with the aim of?
With the aim of allowing it to dynamize.
Yeah, so dynamization. Okay, so everyone can just look at this X-ray and just in their mind decide whether they think this was a good idea and what do they think the outcome is going to be, and then we'll get back to it at a later stage. Okay, so one of the problems with non-unions is that there's a lack of clear and uniform acceptable definitions. So again, asking for a volunteer, what do you guys, how would you define a non-union? Bayanda, your name comes up first here on my Zoom.
Prof, can you hear me?
Yes, I can hear you.
Hi. So there's multiple definitions for non-union, but the one that I specifically remember is a fracture that fails to show evidence of union for the type of injury in terms of bone that is involved, and does not unite at an expected time for that bone.
Yeah, good. So I agree. That's a good definition. It's not very specific, which is a problem. You know, we like rules because that tells us when to intervene and not. So the most acceptable definition in the literature is, according to the US FDA in 1986, and this was actually only really meant to be for insurance purposes. So in other words, when would the insurer pay for the treatment of a non-union? You know, it was never based on any science, and this was if there's no healing at 9 months and no progress in the preceding 3 months. A delayed union, on the other hand, again, something without sort of consensus on a good definition. Nandu in 2014 defined it as a non-union, not a no union, in the expected time frame for the specific fracture. So we don't expect all fractures to heal in the same time. You know, a distal radius fracture heals much quicker than a tibial shaft fracture. That's why it's difficult to apply a uniform definition for all non-unions. So I like this definition, or these two definitions, by again by Nandu and his work on tibial non-unions, because it broadens the definition to non-union to also include earlier cases, and it differentiates between a potential non-union. So potential non-union is any fracture where you take into account the host, the injury, and the management to date, where there's little potential to heal without intervention. You can call it a potential non-union. And as soon as you intervene, whether it's at 6 weeks or at 3 months to achieve union, you've basically defined it as a non-union. And an established non-union you define as no clinical or radiological sign of union in a reasonable time for the specific injury. In other words, you won't be able to have a definition specifying time that applies to all fractures, because we don't expect all fractures to heal in the same time. So before we talk about non-union, it's important to just remember, what do we need for bone to heal? Well, we need an intact osteoconductive scaffold, or we need 2 bone ends that's close enough together. We need the optical mechanical environment, and that basically translates to the right amount of strain. If we have absolute stability and direct bone contact, we get healing with primary bone healing. If we get absolute stability with a gap, we get a non-union. If we get just the right amount of micromotion, we achieve secondary bone healing. And if we have too much movement, we get a non-union. So there's a very small window that we can aim for. We need the right local biological environment. So we need some live cells, and then we also need the right systemic biological environment. And these are the growth factors and the other systemic things that we need to achieve non-union. So Peter Giannoutis from Leeds coined this term in the treatment of non-union, the diamond concept, which I like in principle because it reminds you to think of all the key ingredients for non-union. And he defined the 4 corners of the diamond concept as: you require an osteoconductive scaffold, osteogenic cells, the right mechanical environment, and growth factors. They then go further and say that you should apply this to every non-union to achieve union. And this is like, you know, just shooting whatever you want to shoot with a cannon, basically. Yes, you would achieve non-union, you achieve union, but you don't need all these concepts, because basically they proposed using bone graft, BMPs, revision fixation, and systemic stimulation in all non-unions, which is not the case. So what contribute to a non-union? Well, we have some host factors, and these can be local or systemic. And unfortunately, some of these we can't do anything about. Some of them we might be able to optimize. We have the injury itself, which is very important, and that's an example of something that we can't change. We can't change the energy transfer that occurred to the tissue at the time of injury, and then also the treatment. Just remember, in overall, the incidence of non-union is higher in operative orthopedics compared to non-operative orthopedics. So often we contribute to the establishment of a non-union as well. So again, Nando in his work on tibial non-unions identified the following risk factors for non-union, and these were open fractures, smoking, being HIV positive. It's a little bit controversial because there's several other papers afterwards that showing that there's no difference in healing, including our own host study between HIV positive and HIV negative patients. It's probably more related to the HIV positive patients being more prone to malnourishment and so forth in this paper, diabetes, and then very importantly, internal fixation with a fracture gap, and then compartment syndrome, which is just another indication of a more severe local injury. So it's important to look for all host factors that influence healing. Some of these we can do something about, and some we can't. We need to look at age, nutrition, comorbidities, endocrine abnormalities, of which vitamin D is the most prevalent, medication that interferes with healing, smoking and alcohol, and also the patient's activity. Now, smoking, we know is a big factor that influences bone healing. This is actually a picture of one of my patients, and that conveniently carried his rollies in the UK in his Elizarov frame. Alcohol, I used to say that alcohol doesn't specifically interfere with healing unless you drink so much that you fall over, but there is more and more evidence that excessive alcohol intake has a direct detrimental effect on bone healing. And there's actually lots of medications that interfere with bone healing, not only the obvious ones like anti-inflammatories and steroids. This is a fairly recent paper showing the effect of chronic use of proton pump inhibitors on bone health, and it can also influence healing. Then there's some things that we can't change, and I've showed this video 100 times, and many of you have seen it, but this is one of my actual patients racing his superbike on the Helshoogte Pass outside Stellenbosch, and a poor German tourist that turned into the vineyard there. He didn't see him come on, and he was caught by the CCTV camera crashing at 200 kilometers an hour. And that's something we can't change. So the severity of the injury have an effect on the non-union, and that's something that on the union of bone, and that's something that we cannot change. Like lots of things in orthopedics, there are multiple classification systems for a non-union, and I'll tell you now about the one that I use. That's basically a modification of the best known one, which is the Weber-Check classification of classifying non-unions into hypertrophic, oligotrophic, or atrophic non-unions. It's an old classification. Then subsequently, many other authors try to improve on these classifications by adding and looking at different aspects. Elizarov included in his classification the presence of a deformity and whether the non-union was mobile or stiff. Paley is a more comprehensive classification specifically for the tibia, where he also included bone loss, the mobility of the fracture site, whether there's a deformity, and the leg length discrepancy. Who was actually the first guy that included the presence of infection in his classification system. Then there are more comprehensive classification systems like the calorie scoring system. And unfortunately, like everything, this is quite useful, but once something is so complex that you cannot memorize it, it's not really very useful in day-to-day use, because if you can't remember it on the top of your head, you can't really apply it in your clinical practice. So I like the modification of the Weber-Check classification by Nandu and Len, published in their works on tibial non-unions, and they classify non-unions into 5 different subtypes. A stiff hypertrophic non-union, a mobile A or oligotrophic non-union is grouped together, a mobile pseudoarthrosis, and we'll discuss the difference between those two a little bit later, a segmental defect non-union, and a septic non-union. Now, I would argue that a segmental defect non-union, in other words, a non-union where there's a gap or a large gap, is not really a non-union, because you should have never expected that to heal without intervention. So, and the treatment basically is the treatment for a bone defect. It's a little bit different. And so I really would say that there's only 4 different subtypes of non-unions. So when it comes to the management of non-unions, I really like this quote by famous orthopod called Girdlestone, where he said, "Bone is a plant with its roots in the soft tissue, and when its vascular connections are damaged, it often requires not the techniques of a cabinet maker, but the care and understanding of a gardener." So it's not just about the actual mechanics, is about other things as well. So Nandu basically defined the management as being based on 5 pillars, which is a nice way to think about it. And these 5 pillars include optimization of the modifiable risk factors, mechanical alignment, stable fixation, biological stimulation if necessary, and early functional rehabilitation. And they then devised this algorithm that's really aimed at the treatment of tibial non-unions, but that applies to non-unions anywhere in the body. And you can basically see here that after initially optimizing the host factors, answering whether the non-union is infected. If it's infected, that's an infected non-union, and that's treated according to the treatment principles of chronic osteitis. Then next question is whether there's a bone defect. If there's a bone defect, this is treated according to the algorithm for bone defects. And then to really distinguish between the 3 main different types of uninfected non-unions, you need to assess the stiffness and the radiographic appearance. And this is a stiff hypertrophic non-union, a mobile atrophic or oligotrophic non-union, and then a mobile hypertrophic non-union, or a so-called spinous pseudoarthrosis. So as part of our host workup, the history is very important, and this includes the history of the index event, also history of the previous procedures, retained implants, history of antibiotics, other medication, your general examination, and then local examination, very important, the state of the soft tissue, whether there's pain at the non-union site, look at the adjacent joint, and then also look at the neurovascular symptoms. So to classify the local disease, like I said, you need to look at the soft tissue, the stability, the adjacent joint, the neurovascular status, then look at the radiological appearance, decide if it's infected, and then you can decide on the non-union type. So just a word on infected, sometimes it's obvious, like in this case, but often not. So with a non-union, there can be no hard signs, so there can be no sinus or no wound dehiscence or no cellulitis. And the history here is very important. So again, unfortunately, patients often don't volunteer that they had an infection after their surgery. Lots of my patients are asked, have you ever had an infection after any of the surgery? They say no, but if I ask them, Was there any problems with the wound healing or antibiotics? And then they say, yes, they actually had a vacuum dressing for 2 months after the surgery and they had multiple courses of augmentin. So it's important to ask these questions specifically. Was there problems with the wound healing? Did you take antibiotics for a prolonged time? Did you have a sinus? And then important to distinguish here between active infection with hard signs or sort of low-grade or quiescent infection, because your treatment might be different. Special investigations, these are mainly aimed at identifying modifiable host factors, and then occasionally, if the diagnosis of the non-union is not clear. So my strategy, and this is probably for me the most important slide, when it comes to addressing non-unions, like in many other complex problems in orthopedics, there are multiple solutions, and we might disagree on how we're going to do it, but as long as you state clear goals, I would agree with your treatment if I think the goal is achievable through your plan. So always with a complex problem like a non-union, I think it's good to state the aims of your treatment. And the first thing to state would be like in a polytraumatized patient, you always start with the phrase, you're going to manage the patient according to ATLS principles. If you just simply say you're going to stratify and optimize the host, that would assure your examiner that you are thinking about more than just the fracture. So you're going to stratify and optimize the host, then always first think about optimizing the mechanical environment. And we'll discuss a little bit about that later, even in so-called atrophic situations. Then I think you should always think whether you need to add biology. This is not always necessary, but you should say whether you think it's necessary or not. In all non-union treatment, send off tissue cultures in my series, and in the literature, 50% of non-unions without any hard signs would have positive tissue cultures, and that means that there's the co-presence of a low-grade infection. Infection doesn't cause non-union. Again, Nandu sort of coined the best phrase for me, which is that they coexist in a similar environment. And because some of the soft signs of infection and non-union very much overlap, so yes, there's some inflammatory tissue, the presence of positive cultures, then confirming the diagnosis that it is a infected or a low-grade infected non-union, and then we can treat the infection concurrently. This doesn't mean you need to biopsy it before the time. If there's a low-grade infection without any hard signs, you can simply do tissue cultures at the time of your non-union surgery, and if it's positive, manage the infection concurrently to your non-union treatment. And then early functional rehabilitation of the limb. And remember the AO dictum, that movement is life and life is movement. So optimizing the host. Unfortunately, there's many risk factors that we can identify, but there's not so many that we can do something about. We can ask patients to give up smoking and excessive alcohol uptake, but that's not always, or that's rarely successful. We can avoid certain medication affecting healing, and anti-inflammatories here is important. Once or twice anti-inflammatories in a patient perioperatively after fracture care, this definitely does not impair healing, but in a patient with an already compromised healing like a non-union, long-term anti-inflammatories is important to avoid. Steroids, attention to nutritional status. This is something that we can often optimize. Correct anemia and vitamin D deficiency. Both are associated with an increased risk of non-union. If your systemic conditions are uncontrolled, like diabetes or hypothyroidism, again, it's important to say that AOS recommend no elective surgery to any patient for HbA1c of over 10. because of the increased complication rate and a decreased success rate. So it doesn't matter how painful your non-union, I will not offer you surgery if your HbA1c is over 10. And in some sort of fields in orthopedics, the recommendation there is even lower, like arthroplasty, below 8 or even below 7, which is the treatment, which is the aim. So treat infection aggressively and psychological support. This is the paper showing that they investigated every patient like we do for non-union, and they found an endocrine abnormality in a high percentage of patients, and these were mostly vitamin D deficiency. When it comes to optimizing the mechanical environment, well, there's just really two things that we can manipulate. We can manipulate the stability of our fixation by making it more or less stable, and then we can manipulate the fracture gap. This is a very nice read. I include this slide in almost all my talks because I'm hoping that I'll eventually get everyone to read this paper. It's a nice summary of all the different theories of bone healing. It's not a scientific article. And what is nice about it is that often the different theories like Wolff's Law or parent strain theory are presented as separate concepts. And this paper basically just sort of combines and highlights the valid aspects of all the different theories. And then they conclude, they suggest that the majority of non-unions will heal in the correct mechanical environment, and it's not necessary for biological adjuncts like bone graft in the majority of non-unions, which I agree with. So when it decides what to do, well, we should ask yourself, are we going to do the same thing again? Sometimes we do, especially if it was badly done. Are we going to try something new? And then it's very important to ask yourself whether you should refer the patient to a specialist, especially if you don't know what to do. Well, biological stimulation, and here are some different options. This includes systemic enhancement, bone graft and substitutes, also called orthobiologics, and then also bone growth stimulation. So there were a few words about each one of these. And first, looking at systemic enhancement. Systemic enhancement, probably vitamin D is the most important. Unfortunately, like with any of these, that they might form part of your comprehensive strategy for a non-union, but often with an established non-union, just addressing one of the aspects is not going to achieve union. In other words, once you have an established non-union with poor mechanics, and the patient is vitamin D deficient, just correcting the vitamin D is not going to achieve union. So this is often done in parallel to treating the mechanics of the non-union. The same with teriparatide is definitely shown that it increases healing when used in fractures in high-risk patients. You're not going to achieve healing in an established non-union by just prescribing teriparatide, but it does increase the amount of bone formation and the sort of fracture healing in certain problem healing fractures if used as an adjunct. There are some evidence that some of the anabolic agents like growth hormone, testosterone might increase healing time, but again, it's not going to achieve healing as a standalone treatment in non-unions. So this lecture is not about bone grafts and bone graft substitutes, but they are adjuncts that we sometimes use in the treatment of non-unions. And just a reminder that autogenous bone graft is the only graft that basically supplies all the three properties of the ideal graft, which includes osteoconductivity, osteoinductivity, and osteogenic cells. So when you think you need a bone graft or a void filler, I like to think of it like this. You should select the graft that supply what the host lacks, and the host should supply what the graft lacks. So In other words, if you just have a void and healing is not a problem, you need to select a void filler. If you want to stimulate healing, then you need to use something with the best modalities of enhancing healing. So autograft can be harvested in different forms, and which one you're going to use is going to depend on the specific clinical scenario for a specific case. So remember, allograft in South Africa is fresh frozen and lyophilized and irradiated. So it has some osteoconductive properties. It has some osteoinductive properties by containing some proteins that can help with bone healing, but it doesn't have any live cells. And again, it comes in a whole lot of different forms, but its main use is as that of a void filler, because autogenous bone graft will have better properties of enhancing healing. When it comes to the bone graft substitutes, and there's a long list, this is a big money industry, and that's why almost every single implant company have a form of a void filler. Again, the void fillers comes in different forms: powders, pellets, putties. The main use is their osteoconductive properties, so that makes them useful void fillers. Some of them contains BMPs, and like Allomatrix from BMG, and they might have some osteoinductive properties. For me, I only use them when I want to deliver antibiotics. You must select your void fillers according to where you work. So things are a little bit different in South Africa. In most of the world, cadaver bone or allograft is very difficult to get a hold of and very expensive. In South Africa, it's much cheaper than synthetic graft. So in other parts of the world, when you have a void, synthetic graft fillers are much cheaper. I only use synthetic void fillers when you want to deliver antibiotics, because actually allografts are much cheaper. We just have a lot of dead people in South Africa, and therefore it's cheaper than synthetic graft. So in South Africa, autograft is a gold standard when you want to enhance healing. When you need a void filler, allograft is the most cost-effective solution. You don't need the morbidity from harvesting autograft, and the synthetic bone graft substitutes are more expensive, but their main use is that some of them are useful in delivering local antibiotics. When it comes to orthobiologics, the BMPs is the best known. There used to be 2, but there's currently only 1 commercially available. And despite a lot of excitement in the literature, there's no proven benefit of BMP over autograft, and it has significant morbidity. And my limited experience of using BMPs can cause a severe inflammatory reaction. It's incredibly expensive. Firstly, it's not available to us in state practice in South Africa, and in private practice, it's not worth the extra sort of motivation and effort to use, because there's no proven benefit over autogenous bone graft. PRP, no evidence in enhancing bone healing, and again, sort of bone marrow aspirate, I would say not very useful as a standalone procedure in non-union surgery, but as an adjunct in treatment of non-union that can sometimes have a place. So like I said, BMP is not cost or effective. PRP, no place. And then stem cells, yes, bone marrow aspirate can be used as an adjunct if you want to add some biological stimulation in non-union treatment. Bone graft simulators, again, probably the best known one is LIPUS, or low intensity pulse ultrasound. There's also devices with electrical or shockwave stimulation that's supposed to help with healing. Lipus is the best known one. Exogen is the trade name. It was formerly a Smith & Nephew product and now by Ventus. And the way it works is a form of mechanical stimulation. And it's, you know, the pulse frequency is supposed to wake up osteogenic cells. It is used in some even public health systems, like in the UK, the NICE guidelines. It is authorized for delayed or non-unions. The highest evidence is against their use, and there's high level of evidence, including blinded randomized controlled trials showing no benefit in the use of acute fractures. This was initially, people thought if it works for non-unions, you might get, you know, normal fractures to heal quicker, and specifically in sport, people, it's quite common practice to use Exogen acutely, especially in tibia fractures. But the recent evidence shows no benefit in the use of acute fractures, regenerating, lengthening of bone transport, and in hypertrophic non-unions. Possibly some benefit in delayed or non-unions of an atrophic type, but again, and often as an adjunct and not as a standalone procedure. So, like I said, in South Africa, in delayed or non-unions, atrophic type, patient that's able to afford, is not doing any harm. That's important, especially patients that are poor surgical candidates and that you want to sort of avoid operating or buy a little bit more time, especially those that can afford it. So before we talk about the specific subtypes of non-unions, so any questions up to there from anyone? Okay, well, if we look at the different types of non-unions, then, like I said, the first type to discuss is a hypertrophic non-union. And this is the radiological appearance of hypertrophic non-union. These are stiff and can be associated with a deformity. If they're associated with a deformity, the gold sort of standard treatment currently, especially in the lower limb, is close distraction with a circular external fixator, which we discussed now, which sounds a little bit counterintuitive. If there's no deformity, you can consider closed nailing in a long bone. Just important to remember here that the canal is often shut off, and you need some special tools to perform what I call a canalplasty. Beware of the mobile non-union that appears hypertrophic on imaging. This is a pseudoarthrosis. So true hypertrophic non-unions are stiff, and with the pseudoarthrosis, the non-union site has lost all its biological ability to heal and needs to be treated with aggressive resection and getting healthy bone ends to heal. So when you have an hypertrophic non-union with a nail, this is one of the commonest errors that I see in people that try to treat non-unions, is that they have a hypertrophic non-union with a nail in situ, which is a sign that there's not enough stability, and then they treat that with dynamization. Okay, so basically that just makes it more unstable and makes a more hypertrophic non-union. So for those, so with a nail in situ, the first line would be an exchange nail to make it more stable. You can use controlled compression to make it also more stable. It's a bit harder in the metaphysis. So in the metaphysis of bone, an exchange nail doesn't really make it much more stable. And here you should consider compression plating or the old procedure, and that's described called Jude decorticating. So when I heard this the first time, I thought the person that talked about it was mad, because I was taught that you have a non-union and it has hypertrophic, there's not enough stability, and now you want to treat it with distraction. But this is actually a very nice example of parent-strain theory in action. So with a hypertrophic non-union, there's fibrous tissue in the gap, but the biological capacity of the bone ends is still there. and this tissue in the gap can convert into bone in the right mechanical environment. So you need less stability and less strain. And remember, strain is calculated as change in gap over gap. And the nice thing about how can you have the most profound effect on strain is by decreasing X and increasing Y. So by distraction, you make it more stable and you reduce the movement. So you make X less and you make the gap bigger by increasing Y. And you have a very profound effect on the strain. And with close distraction of tibial non-unions, this paper showed a 90% success rate. So in an atrophic or oligotrophic non-union, this was thought traditionally to be avascular, and this is not the case. In studies, there's good vascularity histologically. And for those who've been in theatre with me, you can see that with atrophic non-unions, they are still, bleeding at the bone ends. You still need to first optimize the mechanical environment. Think of it this way. Remember, according to Perrin's strain theory, when will you not see callus? Well, you won't see callus if the strain is too low. So you get primary bone healing, so less than 2%. And you won't see callus if the strain is more than 10%. So if a fracture is fixed, especially fixed inadequately, and there's no visible callus or fixture of the gap, what is more likely? That fracture fixation is so stiff that it's not giving any callus, or that it's too mobile. It's much more likely to be too mobile. However, in an atrophic or oligotrophic non-union, I think you should always consider biological stimulation, or say you would consider biological stimulation in the exam, but it's not always necessary. And again, in a series of 144, I think, tibial non-unions, there were 33 atrophic or oligotrophic ones achieved union in 100% of them, and only 7% required bone graft. So 26 of them healed with only addressing the mechanics. Very important to identify the mobile pseudoarthrosis, and the difference here is that there is no pain. So the non-union is completely mobile. It often has a hypertrophic, or at least a oligotrophic appearance on X-ray, and is completely mobile. And in this case, there's actually no longer any biological capacity to heal. The bone ends covered in cartilage, is often synovial fluid and synovium, and you need to excise and reconstruct the bone defect. As you can see here, this is quite rare. This is a tibial pseudoarthrosis from a long-standing tibial non-union, with a lot of extra bone formation, completely mobile and painless. And you can see treated there with excision and nailing, and then leading to uneventful healing. So just another word on so-called segmental bone defect non-union. This is a Eastern Cape classic. I think this patient was referred to me after something like 18 months. He was initially in a monolateral X-fix and then in a POP, and his leg hasn't healed in 18 months. This to me is not a non-union, because there was never any realistic chance of this healing. Osteoblasts don't jump, and this is just a bone defect that was untreated. And the treatment here, there's a lot of overlap with the treatment of non-unions and bone defects, because you're also going to optimize your host and look at those sort of those factors. But the treatment here is reconstructing the bone defect according to the reconstructive ladder, the reconstruction that's specific and that's appropriate for that size defect in the specific bone that you're dealing with. Infected bone union, again, the aim here is different. The aim here is to achieve union and to prevent chronic osteitis. Often infected non-unions will have implants in situ. And the big question here is whether you can retain the implants or not. This is really the treatment algorithm of fracture-related infection and not the topic of tonight's topic, but it's really based on whether there's still potential to unite and whether the treatment is still stable. So if there's potential to unite and the treatment is still stable, you can retain the implants and treat the infection until the bone is healed, and then treat the infection afterwards. If there's no potential to unite and or the fixation is not stable, then you need to treat it like structural osteomyelitis with a bone defect according to that algorithm. So again, this slide summarizes the sort of flow diagram of the treatment of the workup and the treatment of the different types of tibial non-unions, but it really applies to non-unions in most regions of the body. So then we go back to our case. So as I said, this was now done at 7 months. This non-union was treated with dynamization or dynamization of the nail. So now I'm going to ask for a volunteer again. Someone else, not Peter, not Bayanda. What do you think is going to happen? Is this going to be successful? What do you think is going to happen?
Maritz, as you said, the issue here is not the issue is that it's already unstable based on the way that they've fixed it. So removing the distal screws in an attempt to dynamize is only going to make it more unstable and less likely to heal.
Exactly. So this is, thanks Dane. So basically this is then another 14 months later. This is now 21 months after the injury, after that dynamization, and you can now see that the sort of ligotrophic non-union is just becoming more and more hypertrophic, and it is 21 months after the patient's injury and she still has ongoing pain and symptoms. So Dane, what now? What would you do? What would you do next?
Refer to a specialist.
Okay, you are it's your CFIB rotation and you are the specialist. So the first question, what are we dealing with? I mean, it's a hypertrophic non-union, and what would you do?
So stratify and optimize the host, as we've said.
Okay, good. There was no real optimizable host factors.
And her limb itself, I'm assuming it's, there's no vascular issues or previous radiotherapy or anything like that. So it's a healthy limb which has got potential to heal. So the issue here is stability. You don't necessarily need to add biology. So we need to make the fracture more stable. So we can consider various options.
Yeah.
In this case, I think a better done nail would be a good option.
Okay. How would you do that?
I'm sorry, Prof. It's Bayanda. I've got a question.
Yes, go for it.
Hi. So where does this patient have pain?
At the non-union site.
Okay, proximally.
Yes.
Okay.
Why? Why do you ask that?
I'm asking. Sorry, Dane, to jump in. I'm asking because I was thinking. I wanted to actually do an antegrade versus a retrograde nail for her.
Okay,
but
good.
I wanted to find out when I say a nail, sort of an exchange nail that's thicker. The reason I wanted to find out was because if the non-union was mostly, I needed to find out if it's more distal or proximal, because I needed to know if I wanted to compress it proximally and if I needed to address anything more distally. But if it's just if she's got pain proximally, I'd be, Basically, how I try to think of it is you try not to do the same procedure that was done before.
Yeah,
However,
that's a good strategy. You know, I often think there's sometimes a certain situation we do the same thing, but often I would do the same thing if it wasn't done correctly, or like sometimes, like with an exchange now, we do the same thing again, but we follow principles. So the principles here, you know, I was hoping people would say an exchange now, and then just want to remind you that the principle of an exchange now, it has to be reamed, and you have to go up a size. Otherwise, you're not making it more stable. So in this case, when it comes to retrograde nails, is that the biggest retrograde nail available is a 11.5. So if you already have an 11.5 nail, then you cannot make a bigger nail. So in this case, the patient already has an 11.5 retrograde nail in. So just reaming and putting in another one would you know, not necessarily make it more stable, and that was my concern as well. And here there's more imaging, but the distal fracture is actually united, and in this case I did that. I elected to do it, remove the retrograde nail and insert the antegrade nail, because the antegrade nail could go up a size to a 13 nail, which is even thicker. And now follow it all the principles of an exchanged reamed nail. So now they have you on the run. What now, Bayanda? Do you think this is, what do you comment on the X-rays there? Do you think it's going to work?
Okay, so what I've got is a antegrade nail. The distal screws are locked in the same plane. The size.
Now you can't see the size, but I promise you it is fatter than the nail that was in there.
Sure. You know, Prof, this is a stable fixation. I don't see why after you've optimized your host, you've done your principles, I don't know why she would not unite.
Yeah, so things unfortunately doesn't always go according to plan. So this is now another 6 months later. This is now 27 months after the injury. And, you know, there's always another good example. Just, you know, you sort of convince yourself on the lateral, maybe there's some callus, but just remember that the non-union is in a specific plane. So, and you know, unless you look down that plane, ongoing pain, and CT scans show a persistent non-union 27 months after the fracture. So it's just 2 years and 3 months. The fattest femur nail in situ, and no identifiable host factors to optimize, or even although the patient is older, I think she was 40 odd, and you know, but nothing that we can make better. So what now?
Add a plate.
Okay.
Add a plate. Who said that?
Peter.
Yes, I think, you know, then you know, you can't keep doing the same thing. So you need to add is, how can you make this more stable? You can't make this more stable with a nail. And you can also, you know, think in this case that it is quite an oblique fracture. So there's some shear forces there. So you need to neutralize the shear forces, and you need to do that, but by adding fixation 90 degrees to it. So there's a lot published, also a paper now recently about adding a plate or interfragmentary screw with a nail. Now in this case, I don't think there's any space for interfragmentary screw, so I put a plate, and the plate is in 90 degrees to the plane of the non-union with compression. So for the first, you can see there are two unicortical non-lock screws, but the first two lock screws was inserted with maximal compression, and then luckily, finally, another 4 months later, which is now 13 months after the injury, the patient's femur fracture was united. So this just illustrates the difficulty and why I show this slide, that the complication rate, there's no guaranteed of 100% success without any intervention in non-unions, and your success rate's usually around 80 to 90% in selected surgical cases. And that's pretty good, if you compare this to surgery for, shoulder surgery or rotator cuff. Don't tell Professor Roche, but I mean, the success rate there is what? Is 10 or 20%. Never mind failure rate of 10 or 20%. So anyways, but the important message here, this is in selected surgical cases. So if you're going to operate on anyone with a non-union, including bad type C hosts, you're not going to achieve a 80-90% success rate. The first step is selecting appropriate surgical hosts, and then optimizing them and treating them, and then you can achieve a high success rate. And I like to think, especially in cases where you do big bony resection, is what is the worst thing that can happen? Often a patient, especially when it comes to infection, with a low-grade infection, and a bit of a draining sinus and an infected non-union, is better off than an attempted treatment where we do a big segmental resection of the bone and now it doesn't heal. So that's why it's important in those cases to rather do nothing. Very important to select the appropriate host. And then factors associated with treatment failure, well, no surprise, smoking, excessive alcohol intake, time from injury, and malalignment. So very important. Time from injury is after successfully treated non-unions 5 or 10 years after the injury, but the longer the time after the initial injury, the chances of success decreases. So now looking at a few specific clinical scenarios just across the body, just to try and have some sort of a protocolized approach. Well, firstly, if you look at the humeral non-unions, this is a systematic review looking at a lot of different treatment options. In the humerus, there's a higher non-union rate associated with the treatment of humeral nails. We've never been a high volume nailing center. That's why we don't see so many non-unions, but I do treat a fair number of humeral nail non-unions, specifically in private practice, from nails done elsewhere. And exchange nail does not have the same success rate in the humerus and other bones. So you can see here that the union achieved in 98% of cases with a plate and bone graft, and 95% cases with a plate. So it's only very select cases where you need to add bone graft. You can achieve a high success rate with compression plating alone. Also with X-fix and frames in the upper limb, although the complication rate and the tolerance of the patient is a lot poorer. So basically I try and avoid frames in the upper limb as much as possible. One of the problems is of non-unions in the forearm is that you cannot shorten, do significant shortening in the forearm due to the two bones. In the humerus, you can do large shortenings without any problems, and even a simple non-union, after you've debrided it to healthy bone ends and revised the fixation, you lose a couple of centimeters. Now in the forearm, where you can't shorten after debriding, you often end up with a 1 or 2 centimeter defect. So in the forearm, structural bone graft works very well. In this paper, 83% success rate. They say defects up to 5 centimeters. I've definitely done defects up to 7 or 8 centimeters, but it depends a little bit of the size of the iliac crest, because you need to harvest a continuous tritocortical piece of iliac crest and plate that with compression. Another common scenario is a lower limb long bone non-union nail in situ. Now this is one place where an exchange nail is always the first line. And in the femur, an exchange nail, a single exchange nail, achieve a success rate of 90+%. But you need to follow the principles of an exchange nail, which is that the nail should be reamed and you should go up a size. Unfortunately, like anything in the tibia, the success rate is lower. And this paper quotes it at 63%. In my case, it's around 70%. But I would say 60% success rate with a single stage exchange nail for the tibia. In many places, even for infected nails, the first line treatment would be an exchange nail, although infection is a risk factor for failure of a single exchange nail. And this is a big paper from Scotland by Professor Hamish Simpson, where they treated 102 tibial long bone non-unions with an exchange nail, including infected unions. And some of the patients had up to 4 exchange nails before they achieved union. Now, personally, I don't ever do any more than 1 exchange. So once I can't keep doing the same thing, and expect a different result. So once I've done an exchange nail, I sometimes do get patients that's had an exchange nail where I thought that maybe, it wasn't optimally done or the principles wasn't followed, where I would try it again. But in general, I just do 1 exchange nail and then I look for a different treatment option. But in their paper, infection, an atrophic pattern, and a gap of more than 5 millimeters were risk factors. These are a few papers looking at plate or screw augmentation to lower limb long bone non-unions with a nail in situ. And often the case when the initial technique was described, we were all very excited and thought it's the solution to all the problems. I've tried it for multiple different cases, and like most things in the lower limb, it works well in the femur, doesn't work as well in the tibia, but in the select right cases where you can improve the biomechanics by plate augmentation, it does work well, and more so in the femur than in the tibia. And one of these areas is this subtrochanteric region in the femur, which is very problematic. So luckily, the incidence of non-union is not that common. It's 5%, but if you think of Pertrogues with a non-union rate of about 2%, it's more than double that. Risk factors for subtroch non-union is mole reduction and atypical fractures, as we see on people on bisphosphonates. And if you think of the principles of how a exchanged nail work, even when you change the nails to a thicker diameter, the proximal part of the nail often remains the same. So in other words, you don't really make a proximal fracture more stable with an exchanged nail, except in very specific cases where you can change from one implant system to another one. So often in these cases, I do an exchanged nail and plate augmentation to really increase the stability. Or in cases with a deformity, it's very difficult to correct the deformity with a nail in situ with another nail. The nail just goes down the same canal. So either corrective plating and then nailing, or all the implants like a blade plate is very useful. And in some cases, especially over low demand patient, it's better to just go for arthroplasty because the reduction really is paramount. Now, tibial non-union with a nail in situ, the first line treatment is an exchange nail unless it's infected. Slightly less commonly performed is tibial nailing for non-unions without a nail in situ or not previously treated with a nail. And this was Nicopotmus met, where we looked at a number of cases that we treated, and here suprapatellar nailing really helps us to push the boundaries, because often these cases have a deformity, the canal is completely shut off, and you need to pass some special tools. Now, this was very difficult with the infrapatellar approach because you were doing a difficult part of the surgery while trying to cross the non-union with the patient knee inflection, and you can't screen properly. But the suprapatellar approach enables you to have a straight working channel and just helps us to nail more and more complex fractures. In our paper, this initial series, which achieved 100% success rate with union, with treating non-unions not previously treated with a nail, with nailing. And so post-frame or post-X-fix non-unions really does very well with a nail. So when I have a non-union in the frame or in an X-fix, my first question always is, if the soft tissue is healed, can I treat this with a nail? So before we look at some cases, just the take-home message, as I said earlier, is to give attention to the host, the importance of looking at the mechanical environment first, have a specific treatment strategy for the specific types of non-unions, and then to clearly set out your treatment goals and then decide how you're going to achieve it in the exam and also in real life, because we might disagree on the specifics, but as long as we, as I agree with your goals and think that your chosen treatment would be successful, then I would agree with your treatment. Any questions before I show a few more cases? Any questions from anyone?
Hi, Maritz, it's Ashley.
Yes, Ashley.
I have a question about, that whole titanium cage thing, the 3D printed titanium cage. Do you think it will sort of supplant bone transport, sort of fractures with defects?
I definitely think so. Like anything new, I would just express some caution that I don't think it's the solution for everything. I mean, I've done a number of cases now with good success in carefully selected cases. I'm sure there will be complications going forward, but specifically in the femur, frames are not well tolerated and bone transport is very difficult. And I think in general, the sort of limb segments with better soft tissue supply, infection is less of a problem. So I really think for large bone defects, specifically in the femur, it's a very exciting development. And I think we're going to do more of that because it seems to be quite predictable, good results, much quicker treatment time compared to bone transport, actually cheaper than bone transport and actual cost because of the implants, cheaper than a frame for bone transport, and also much more convenient for the patient. I would still be very cautious in the tibia. I can just see that when people use this frequently. I have done a tibial case that was successful, but it was just in a carefully selected patient. I think specifically in the diaphysis and post-fracture cases with implants, I think there'll be a high complication rate if it's used frequently. And frames work fantastically well in tibia, so I don't think it will really replace bone transport in the tibia, but in the femur for sure.
Thank you. I have a second question.
Yes.
In terms of, let's say, infected non-unions, where you have a stable implant, does this time factor affect your management? So let's say someone presents to your clinic, 9-month-old fracture, implant stable with a clear draining sinus. Does that change your management, having had the implants for so long? Do you think about maybe exchanging the implants or something, even though it's stable because it's been such a long time?
Yes, it definitely plays a role, because I think there's one thing that you need to sort of separate in your mind here, and then the one thing is success with union versus success with eradicating infection. And you're very unlikely to successfully eradicate infection after sort of 10 to 12 weeks with a fracture-related infection. So if I have let's say infected tibial nail at 9 months, you must know that you're unlikely going to effectively eradicate the infection. But at the same time, if you have serial x-rays where there's progression in union, the implant is still stable, and every x-ray shows progress, well, then you can just, especially if the infection is not causing a lot of morbidity, you can just not treat the infection or try and suppress the infection till you achieve union. So yes, time definitely takes it into account, because it's not only about stability, but it's also about progress. So if the implant's loose, there's no point in keeping the implant. If there's no progress, well, then you have to intervene anyway. But time frame is important from the point that you are less likely to successfully eradicate the infection by keeping the implant. But sometimes you would still keep the implant because healing is imminent, basically.
Okay,
Does
thanks
that
very
make
much.
sense?
Yes, thanks a lot.
Cool. So actually, then while I have you on the line there, let's ask your opinion about this case. So this is a 40-year-old previous tibia fracture. I think it was here. If you look at that stigmata of an old X-fix there, this was treated with a non-union machine, which is a monolateral external fixator. And the patient has this radiological appearance with pain at the old fracture site.
I think my approach to this patient would be initially to optimize the host,
Okay.
and identify any modifiable factors that I can change. Looking at the X-ray, so I'd assess the patient clinically. Looking at the X-ray, it seems to be a hypertrophic non-union, but I'd assess the patient clinically just to see if it's stiff or if it's painless and mobile, which is indicative of a pseudoarthrosis.
Okay. So this guy walks without crutches. He works. He just has pain. He's taking painkillers every day, but he walks without crutches. You can't elicit any movement at that site.
So since it's a hypertrophic stiff non-union, the issue here is that there's a deformity. So it would preclude me from nailing him. So my management here would be a TSF type frame with a distraction and slow correction of the deformity. So distraction, osteogenesis, and slow correction of the deformity.
Yeah, good. So just remember there that it's not distraction osteogenesis. It's not the same principles, because with distraction osteogenesis, you distracting an osteotomy and bone forms there. Here you have fibrous tissue that converts to bone in a mechanical environment, slightly different, but yes, I agree exactly what you say. Just a word of caution here. Like I said, these cases are often so stiff that you physically can't elicit any movement. So you need to build a very stable frame. So you can see the distal ring block to increase your fixation, proximal ring block, hexapod fixator, gradual distraction. There you can see distracting that stiff non-union about 8 millimeters, and then if you just go back, I think this was an established non-union for 18 months. And then if you look at the dates here, I think this healed in about 3 months, okay, after distraction. So very successful. And then you can see completely united and straight. But also, like I said, fibular osteotomy and a very stable frame, because otherwise you're unable to move them. Okay, let's ask someone else. So this is I think this is an X-ray at the time of the injury. So it wasn't treated by me, it was treated by someone else. There's an open tibia fracture, 38-year-old. And this is how the patient is treated. And this is 6 months later in my clinic. Who wants to have a go?
I'll have a shot. It's
Cool.
Kim.
Kim. So just to show again, so this is the initial open fracture, treated like this, and this is now at 6 months.
So it's got a few problems that I can identify. Number one, there's some bone loss there, and treated with a very unstable construct there, or what you said, the non-union generator with the monolateral X-fix. They haven't compressed the bone and they haven't addressed the bone loss. So they've got a construct that's actually making the strain worse at the fracture site. And I don't see a lot of bone formation there. So I think I would call this a atrophic type of fracture. It's not stable enough to unite.
Yes, I agree. If it's an atrophic type non-union.
Sorry, I didn't address the host factors either, but I would first stratify the host and optimize them. But I just identified those problems so far.
Okay. So while you think of your treatment, just an important thing that you mentioned here is, I mean, the first one to say never in orthopedics, and you know, there's not just one way to treat things, and there are certain fractures that are amenable to treatment at a monolateral fixators. The problem with specifically monolateral fixators designed for definitive treatment, like a Procalus from Orthofix. But if you think at the problem movement with monolateral fixation is shear forces due to the cantilever effect, and you have less of that if you have a load sharing fracture. So if you have a simple fracture or a fracture where there's at least some cortical contact, that cantilever shear force would be, from the cantilever effect, would be neutralized because the cortex. So the fact that this isn't reduced, you know, contributes to the problem. So there's not good cortical contact there. So in other words, any loading here by bending of these pins would lead to some movement in the horizontal plane here at the fracture site. Now, yes, there might be a little bit of bone loss. Sorry, I skip forward there, but you know, the bone is really there. It's just a loose butterfly fragment. We'll get back to that now. You can see here that this X is completely loose. So now we used to use quite a lot of like Procalus Orthofix cases because we didn't treat any open fractures with intramedullary nails. That was a policy. So nowadays, I would just say that the fractures amenable to treatment with a monolateral system like the Procalus, we all treat with nails. So when last did you see a simple horizontal fracture with terrible unclosable wounds? I mean, unfortunately, it does occasionally happen, but it usually goes hand in hand. So the severe fractures of comminution are the one we treat with X-fixes because they can't have a nail primarily. So there's more simple fractures with simple wounds we end up treating with a nail. And if you're going to choose a monolateral fixator, it must be one that is designed for definitive treatment, not like this, which is a JEDEC. So that's just my two words on that, and then I would add that it's it's so simple to put on a circular frame that it's not necessary to try and push the treatment indications of temporary fixators like this. Okay, Kim, so you've had a chance to think now. So what would be your goals of treatment here?
So my goals, being an open fracture, I want to exclude an infection, stratify and optimize the host.
How are you going to expose it? How are you going to exclude an infection?
I would build it into my plan for the non-union. So okay. If I was concerned at time of treatment, I could decide to do a biopsy if needed. You could also do your workup, including your bloods, CRP, white cell count, identify obviously any sinuses or any signs of underlying infection.
Okay, so this patient didn't have any hard signs, but I agree with you. I would always look for soft signs, and if I do an open approach to non-union, I would always biopsy it for sure. And so, your goals of treatment would be? My goals of treatment would be to increase the stability of the construct, as well as to obviously maintain alignment, but to compress across the fracture site to get cortical compression. I don't think that we need to address the biology in this because I think a mechanical biological approach, the mechanical stability approach would be sufficient for union. Okay. So what would you do? How would you achieve those goals?
It is past quite a significant time past the injury. You could still consider doing intramedullary nailing, but I would have tools there available in case it's difficult. So solid reamers, I would have a plan if you needed to open, and at that point I would do a biopsy as well. The other alternative would be to put on a circular frame and to keep the alignment and to increase the stability of the fracture.
Yeah, look, I think those are all right. Actually, looking at this, I can't remember why we didn't nail it. So just a word to just remember, you know, it's always a bit weird when in acute fractures we say that we don't want to convert as X-fix to a nail after 14 days because the increased infection risk, and that is true. The infection rate does go up, but I, usually just look at the pin site history. If the patient had dry pin site, never had any problems with infection, I'm happy to convert it to a nail in the same sitting, even if the X-fix is on for a year, 2 years, 3 years, however long. However, if you are worried, then you can always do it as a staged procedure. So you can take X-fix off, give a pin site holiday, sort of wait 3 to 4 weeks, and then put a nail in. So this is what was done, what I did, and I actually can't remember why we didn't nail it. Because if I look at that now, I think my first thought would be just like yours, to nail it. I can only think that if you look at the size of these holes in the tibia, he must have had terrible pin sites. So we elected to go for an closed Ilizarov treatment, so no graft or anything, just optimizing the mechanics of the bone that is there, aligning it, and you can also see a fibular osteotomy or partial fibular excision to really divert all the mechanical forces through the tibia, and then patient healed. You can see there without addressing, without adding any bone graft, but the bone was there, just sort of needed to heal in a short time. Okay, so this is another case. This is again sort of preceding our care. This is a 27-year-old music professor, the humerus fracture. This is how it was treated with an intramedullary nail, and this is now 15 months later. Who wants to have a go? Benjamin, are you there? Your name's just after Bayanda's.
Hello, Prof. I'm here.
Benjamin, can you see? What do you think? What are we dealing with?
So this is an established. It's an established non-union. I think it appears to be a hypertrophic non-union. I'm unsure if it was causing pain, but the images you showed before showed some deformity as well. So to start off in terms of management, I would want to stratify and optimize the host to see if there are any things I could improve, and then try to improve stability. Obviously, it's not a weight-bearing bone, so using an intramedullary device may not have contributed much to stability. So I'd want to revise that. I would want to improve the stability by considering a plate, and probably acute shortening to freshen the bone ends, and then getting some compression with a plate.
Oh, with leaving the nail in or taking the nail out?
No, taking the nail out and then and then plating, because I saw one X-ray before this that showed some deformity as well.
Yeah, and I think it might not project so well on your screens, but if you look carefully here, this nail is completely loose. There's a large lytic area around the nail. This was actually completely mobile. I didn't have much pain. And let me go back to the initial X-ray there. You can see obviously it didn't have initial stability. Nail wasn't a good choice here for a comminuted fracture with such such a wide canal. And this was actually a pseudoarthrosis of the nail in situ. You can see all the movement there. It was completely mobile, didn't have any pain, large lysis around the nail. And again, this is cases where people describe of humeral non-unions of a nail in situ, just adding a plate, but just adding a plate is not going to do anything. You know, you need to treat it more aggressively. So we did that by taking it out, debriding it, shortening, sort of correcting the deformity, almost like a bayonet apposition, you know, pushing in the distal. As you can see now, there's a bit of a mismatch with the size of the bones there. You can see just from this butterfly heel, so then bayonet apposition of this narrow bit into there after debriding down to healthy bone with some shortening. That's the immediate post-ops. And this is then at union.
Union 5 months. Nice.
Okay. This is the last, maybe the second last case. Who wants to have a go here? This is the initial, this is a groot patient, the initial X-ray presentation of a difficult segmental femur fracture. One of those where you're happy you're not on call that evening when you see it. Let's see. Let's ask the current expert, Makize. You here?
Hi, Prof. Yes, I'm here.
Okay, so this I'm just going to show some X-rays. So this is the initially was nail with a recon type kephalomandari nail. I don't have those post-ops, but unfortunately at 10 months, she presented back with that non-union and a fracture of the nail, and then that was revised to this different device. What do you think? Is it going to work?
I'm just trying to have a look. I don't think it's going to work because all they've done essentially is just replaced one, like the similar mode of fixation with the exact same similar mode of fixation, and the nail doesn't look any much bigger than the other one. Okay. Anyhow. So I don't think it's going to work.
Okay, so you're right. This is then another 12 months later. This is now 22 months after the initial injury, and that device is also fractured with a non-union and a young patient, 31 years old. So what do you think? What are we dealing with?
Initially we called it hypertrophic, but it's a stiff non-union with there's no deformity, and it's hypertrophic. I think you need to add in
before you say that, just the diagnosis. What type of non-union is here? Is there lots of callus?
So in that shaft, there seems to be, not in this image, but in the previous one that you showed.
Yeah. Like so if there's some, but not a lot, what do we call it?
Okay, so it would be an atrophic, oligotrophic.
Yeah, oligotrophic. So oligotrophic, there's some callus, but it's not hypertrophic. So I would call this oligotrophic, and but the treatment's really the same. So this is a oligotrophic non-union. Mm-hmm. In what region?
Proximal femur looks to be more lateral.
Yeah, subtrochanteric.
Subtrochanteric, yeah, lateral cortex of the femur.
Okay, and what do you think? There's a deformity?
I think it might be slightly inverse.
Yeah, slightly inverse. Okay, so in her, there's no real optimizable host factors. She's slightly overweight, but otherwise healthy. And so there's no real host workup here. So what would be your goals of treatment here, and how would you achieve those?
I think you want to try and increase the amount of stability that there is.
Okay. Good.
And one of the ways you can do compression plating for her.
Nail out and compression plating.
Yeah.
Okay.
Or you can do two modes of fixation, where you can do a new nail, slightly larger nail, and then put in a compression plate.
Yeah. Okay, so look, I think this case highlights a few things, and since the subtrochlear is a specific problem area with lots of forces, and if you already go back after this first breakage, you can see here that there is obviously a varus deformity, and this new nail that was inserted is in varus. It might be subtle, but if you look at how high the lag screw is in the head after starting in the middle of the neck, this is a 130 screw. So basically, normal, she is in varus. A normal neck shaft angle, there's actually not a 130, I think this is a 120 versus a PFNA, so it's the shaft angle is less than that. So actually this is definitely in varus. That's very poorly tolerated in the proximal femur. You can see that there's a slight defect here that's probably aggravated by this, the fact that it's opening on this side, and it's very poorly tolerated. And then the choice here of an exchange nail, again, like you were saying, you're not really making it more stable, and it's very difficult to correct a deformity with a nail if there's a nail in situ, because the nail just here, the lag screw just goes up the path of one of those other screws, even with different implants. Occasionally you can select a different implant, like if you had a single lag screw, you can double two screws, you can use something with an intertan in a different plane, but in general it's difficult to correct a deformity by using a nail again in the subtrochanteric region. So I would have here chosen for a different modality, maybe plate and nail, like you said. And then, so now, again, we're not going to do the same thing again. So we did a corrective plating. So corrected the valgus by doing a sort of closing wedge through that non-union, excising it and using a proximal femoral plate, like you would do a blade plate, and correcting the deformity and plating it. The distal fracture was united, and this united. So this is another case, just of a forearm 6 months post injury, and you can see here that there's a clear non-union of the ulna, and let me just see, and the radius, it seems, yeah, and the radius. Okay, so who wants to have a go?
It's Mayanda. Please, may I try just?
Yeah. Yes, go for it.
Okay. So we're dealing with oligotrophic non-union of both the radius and the ulna.
Yeah. I look back carefully on the screen. It looks like the radius is united, so it's just the ulna. So it's a oligotrophic non-union of the ulna.
So for this one, it's quite specific, and specific challenge in that this is a forearm, and you can't just treat the ulna without consequence to the radius. Importantly, you have to pay attention to the distal and the proximal radioulnar joint.
Okay,
so in this patient, as per usual, you would do host stratification and correct all modifiable risk factors. And then the goals of treatment would be, if you can go back to the X-ray again, so it's oligotrophic non-union. There seems to be a fracture gap there. The course of treatment here would be so there's loss of bone, okay? There's bone loss, and you cannot, unfortunately, do an acute shortening without consequence. So this is one where you actually need to get a bone graft. And the kind of bone graft that you're going to need for this is going to be structural. So not just cancellous. I would go for iliac bone graft, remove the ulnar plate, take biopsies, take an iliac cortical bone graft, and then do compression, and then do compression plating through the bone graft.
Good, perfect. So that was done. Long plate, tricortical iliac graft, plated with lots of compression. You can see actually it's the same radial plate that's in there, and it's united, and that healed without any problems. Okay, and then last case, I promise. This is a 56-year-old patient, known severe rheumatoid, 15 months following a proximal tibia ORIF, and she's referred to me with this proximal tibial non-union. Who wants to have a go? Let's look for some more of the trauma team here. Brad, are you here? Oh, there's Francis. Actually, we haven't had anyone from the hands team. Francis, are you there?
Yeah, I'm just trying to unmute myself. Hello, Prof.
Okay, we can hear you.
Okay.
Okay.
So we're dealing with a non-union in the metaphyseal area of the tibia. It appears hypertrophic. There's various deformity, and the plate is pulled out proximally. There's also a stiff knee joint with severe arthritic change, which probably is contributing in that most of the mechanical stresses are going through the fracture site when the patient's trying to move the leg. So our goal, obviously, in terms of managing the host, there is rheumatoid arthritis. There are probably medications that aren't helping our situation. So in discussion with the rheumatologist, might be able to modify some factors there. And then mechanically, I would have liked to do a nail, but that knee joint isn't going to let me.
Yeah.
So I would have to look at replating it and possibly doing medial and lateral plating to improve the stability of the construct. Alternatively, perhaps a frame and the distraction.
Yeah, good. So I think it's, like I say, those are all options. The aim here is that you need to make it very stable, and that will be difficult with an adjacent syndrome. This just shows the importance of assessing the adjacent joint. And this is a very stiff arthritic joint. It's a fairly young patient, but this is a severe rheumatoid, low demand patient, and we're often quite aggressive with arthroplasty in this patient. So in this case, I thought, it might be better to just treat this patient with a arthroplasty. So I spoke to Tom, who agreed, and he did a proximal tibial replacement on her. Again, like I said, this is select cases. If I had to treat that, I would have done the same thing. 2 plates. You just realize that you need to make that very stable with the adjacent stiff joint. And that's it.